Good morning, everybody, and welcome back to our Colleen Reentry Initiative Learning Collaborative for the Justice Involved Screening Portal session. This time, this is session 4. We appreciate you guys if you're returning from the first 3 sessions. Thank you for coming back. If you're new to it, we appreciate you coming for the first time. This webinar is going to begin momentarily. Let's go over a couple housekeeping rules here. Your microphone is going to be muted while speakers are presenting or speaking. Please turn up your audio. Please use the Q&A feature to share feedback or ask questions. We will have a Q&A session towards the end of the Justice Involved portal session. Session is also going to be recorded and captioned. Caption recordings and transcripts will be posted on DHCS website within 7 to 10 business days. So give us a little bit of time to get it ADA approved and everything like that, and we'll get it posted so you guys can have it to access at a future time. Next slide, please. All right, as I said, welcome. Today is October 17th, and this is Justice Involved Reentry Initiative Learning Collaborative, Session 4, which will be discussing physical health services, claiming, and billing. Next slide, please. We're doing welcome introductions. As I stated, my name is Greg Tate. I'm a section chief here with the Department of Healthcare Services, Justice Involved Initiative for the Office of Strategic Partnership. Next slide. And here is our team. We're led by our Deputy Director, Autumn Boylan, and I'm one of the section chiefs. Our other section chief on the other side of the house is LaWanna Welsh. I believe she might be on. If not, she's always around and available. Under me, I have 2 unit chiefs, Mr. Michael Gillis and Mr. Mike Kadeen. And under LaWanna, she has a unit chief, Miss Megan Shandell, that you will be hearing from later. Next slide, please. At this time, we would love to hear who you guys are. What is your role in the Reentry Initiative? Please answer the Zoom poll that just popped up right in front of my face. Sorry, but it just popped up. Answer the Zoom poll about who you are. Are you with the county jails? Are you with the county youth correctional facility, county correctional healthcare entity, any county sheriff's office, CDCR or CCHCS, California Correctional Healthcare Services, county behavioral health agencies, county social services, managed care plan, reentry provider, ECM provider, or if you're a other, which some people just come on here just to hear what's going on, please click the other button and hopefully we see where everybody's from and here joining us for this reentry initiative session this time. Give that a couple of minutes to just populate through. I see a lot of people here from the behavioral health agencies. We appreciate you guys coming. They say the session is supposed to have about 500 to 700 people, so we're at 240 right now. So we're just going to give a couple of minutes to let more people populate in and pick. Actually, we're at 340 right now. Sorry. And let people populate and choose where they're from. So I'll give it about 1 more minute. At 10:07, we'll go ahead and move on to the next slide. I think that's good. We got a big population here. Appreciate you coming. A couple of people from the sheriff's office, managed care plans, ECM providers. At this time, I'm going to pass the mic over to Jody Mulligan-File, which is one of our specialists on my team, and she's going to go over the Learning Collaborative recap for session 3. Thank you so much. Enjoy your day.
Thanks, Greg. Yeah, my name is Jody Mulligan-File, and I am a Justice Initiative Specialist. I'm on the Reentry Services branch side of things, and so we're just going to be quickly going through some review and talking about what's going to be coming up next. Next slide, please. So as you know, we're here at the physical, you are currently at the Physical Health Services session 4. Our last session was the Behavioral Health Services session. We had office hours on the 3rd and on the 10th. We're going to have office hours for this session upcoming on the 24th and the 31st. And just a reminder that the office hours we're going to have for physical health services for correctional facilities is going to be on the 24th. And then the office hours following that on the 31st are going to be for other implementing partners. So just keep that in mind. Next slide, please. So just really quick, want to go over the collective norms, the working norms. Just a reminder to stay curious. We want to remain mission driven as we're going through these learning collaboratives. We're all learning together, and we're all working towards the same goals. Be present and interactive. Please feel comfortable and feel open to speak up and let us know what you're doing. We all learn from each other. Think beyond your sector and create. This is a safe space. It's judgment free. So please feel free to share. Continuously provide candid and constructive feedback. Something we like to do within our own teams here at DHCS. Seek opportunities to collaborate. There's a lot of people on these from all over the state. So please, if you hear something that is interesting to you, reach out to that partner and see if you can connect. And remember to be solution oriented. Next slide, please. All right, so this will be a recap for session 3, behavioral health services. This was on Thursday, the 26th of September. And we hosted this was our 3rd learning collaborative session. And we had the 2 office hours that followed. The first for the correctional facilities and the second was for our other partners. So some of the topics covered were improving knowledge of covered behavioral health services. We talked about enhancing the understanding of behavioral health clinical consultation requirements. And we outlined a timeline of requirements for behavioral health links and identified requirements and best practices for administering medication-assisted treatment, medication for addiction treatment, otherwise known as MAT. And we learned from subject matter experts on MAT implementation. Next slide, please. So I want to talk about some of the key takeaways and best practices for MAT. It was very nice for this learning collaborative. We had Imperial County, Sacramento County, and Santa Cruz County on, and then they presented some of their challenges and best practices for implementing MAT. It was really wonderful to hear from all of them. It really, I think, grounds the work when we get to hear what you all are doing on the field. Some of the key takeaways from these presenters, we talked about eliminating stigmas around addiction, very important and always floats to the top. This is ensuring facility staff understand the medical and behavioral impact of addiction and the importance of effective addiction treatment on health outcomes and saving lives. We talked about promoting a collaborative environment among correctional facility staff to identify barriers and solve problems for the effective implementation of MAT. We talked about ensuring that custody is trained to identify needs for MAT at intake. We also talked about utilizing digital health resources, including educational videos for patients on administration of the medications that they were taking. We talked about partnering with substance use disorder counselors to coordinate discharge planning and distribution of medication upon release. And we talked about developing consistent communication pathways between behavioral health providers and correctional facility staff to allow for meaningful follow-ups with patients on the continuation of MAT. And with the next slide, I'm going to be handing this over to Jill Michelle, who can introduce herself and talk about our agenda and objectives.
Thanks, Jody. Good morning. My name is Jill Michelle, and we're so happy that you're here today. Today, we're really going to focus on clinical consultations, labs, and radiology for physical health services. We'll briefly discuss care management today, but we're going to get to that more in learning session 5. So just a touch, not a lot about care management. Today, we want to support your knowledge of what physical health services are covered. We want to improve your understanding of what that physical clinical consultation is. We're going to talk about labs and radiology, services, providers. We want to know, we want to walk through real life scenarios with you. So we have some of those for physical health services. And we also want you to understand the landscape of what's already happening. Our correctional partners provide many of these services already. So it's important to take that into account when we're talking about working in correctional facilities with physical health. So from here today, to get all of that, We're going to review the Federal Consolidated Appropriations Act of 2023. Autumn will do that. We're going to discuss what covered pre-release services are, including the clinical consultation, labs, as I mentioned, and radiology. We're going to walk you through a patient journey to see how that all comes together. We'll have a quick Q&A and a break. We'll briefly discuss the care management. We'll have another activity for the breakout rooms, and then we'll wrap it up and we'll do the next steps. Back to you, Autumn.
All right, thank you so much. Happy to be here with you all today. Thanks to my team for getting the ball rolling this morning. Wanted to bring to your attention and make sure folks are tracking new federal requirements that were passed as part of the Consolidated Appropriations Act of 2023. It does primarily affect youth and youth correctional facilities, and requirements for what youth correctional facilities will need to implement. I do want to note, and we'll get into the details on the next slide, that this is in addition to the 1115 waiver requirements that we are implementing. This is a federal legislation that was passed by Congress and affects all youth correctional facilities across the nation. So these requirements are very closely related to the 1115 waiver that we're implementing as part of the Reentry demonstration project, but it is a different requirement and does apply to all youth correctional facilities. So let's get into the details of it. Next slide, please. As I mentioned, the Consolidated Appropriations Act was passed in 2022. It includes a requirement that all states cover pre- and post-release case management and screening and diagnostic services for youth who are post-disposition in a youth correctional facility. This requirement, as part of the CAA, is effective on January 1st, 2025. However, we will be kind of folding it into the larger JI Reentry initiative. The important thing to note here, though, is that the Centers for Medicare and Medicaid Services released guidance related to this new federal legislation, and this goes beyond the state Medicaid agency's requirement to cover these services. It's actually an entitlement for Medi-Cal and CHIP enrolled individuals. And so for Medi-Cal and CHIP enrolled youth who are incarcerated in a youth correctional facility, it is required for those correctional facilities to provide these services to youth. Now, that being said, the good news is that our 1115 waiver actually covers most of what's required for the Consolidated Appropriations Act. As you know, we already cover pre-release services for a period of 90 days post-release. We also cover post-release care management by requiring that the managed care plans cover the enhanced care management benefit for all individuals who are eligible for pre-release services, and that's for up to a 12-month period, which far exceeds the requirement for 30 days of post-release care management. We're looking at still, and we'll provide some additional guidance about the level of screening and diagnostic services that are required under the Consolidated Appropriations Act. And if those screening and diagnostic services exceed what we are requiring for the 1115 waiver implementation or the Reentry initiative. Importantly, one of the EPSDT screening and diagnostic services has to do with diagnostics for dental care, which is, as you know, not covered as part of the Reentry demonstration. So flagging that for your attention. As I said, we'll give additional guidance. The other thing that's important to note is that this requirement is effective on January 1st of 2025. That being said, CMS is aware and tracking and previously approved youth correctional facilities across the state to phase in over that 2-year period. And so we're seeking additional guidance from CMS regarding expectations, but our preliminary feedback from CMS is that our counties will still be able to phase in these requirements, but it may be on a bit more of a truncated timeline. And as soon as we know more, we will let folks know what to expect. Next slide. So this just goes into a little bit more detail about what I just discussed. I'm not going to repeat what's here, but just know that there's a lot of overlap in what is required for the Consolidated Appropriations Act and what we're already doing as part of the Justice Involved Reentry Initiative. And we will leverage and maximize the Reentry Initiative to the full extent possible to mitigate any additional impact that the Consolidated Appropriations Act may have on youth correctional facilities that will be required to implement these rules. And we will make sure that we provide additional guidance as soon as we have more information from CMS. Next. Okay. I know that there may be questions about that, so please do submit your questions in the Q&A, and we'll do our best to answer them. I will say there is some federal guidance today, and we're still working through some of the details with CMS, so we'll do our best to answer your questions as well as we can. And we will make sure that we get out additional information and have a whole session dedicated to youth correctional facilities in the new year. So we will move on today to start our overview of the covered physical health services and clinical consultation services. So just a little bit of level setting before we get into the content of what is required under the waiver program, but a little bit of kind of context setting as to why. So some of the data that we have available to us indicate that 17% of adults in state prisons currently have an active hepatitis C infection or were at the risk of developing liver disease compared to 1% of the general public. So these are particular concerns for the incarcerated population and those leaving incarceration, and a particular need that can be met through treatment and stabilization services during that pre-release period. We also know that about 26.3% of incarcerated individuals have issues related to high blood pressure and hypertension, compared with only 18% of the general population. 15% have asthma, and 65% utilize tobacco, compared to only 21% of the general population. So the health outcomes and the health risk factors for this particular population are significant compared to the general population, and hence kind of our inclusion of physical health clinical consultation services as part of this reentry initiative. We also know that the mortality rate for individuals leaving prison is about 12.7 times higher than the mortality rate, which is largely driven by opioid overdoses, which we talked a lot about that behavioral health clinical consultation in the last meeting. But part of our goal for this reentry initiative is really to tackle these issues while the individuals are still in custody, make sure that there's an appropriate treatment plan for pre-release services, and then also make sure that care is continued into the community as part of that reentry planning that will be happening as part of the warm handoff requirements, so that we can bring these numbers down and start to improve morbidity and mortality rates for people who are incarcerated or formerly incarcerated. Next. The covered pre-release services do include physical and behavioral health clinical consultation services. So we talked about that last time. And it includes laboratory and radiology services. So those ancillary services that are needed to help diagnose physical health conditions. So the primary purpose for these services is to diagnose these conditions, whether they are previously known or not previously known. We want to make sure that that these health conditions can be identified while the individual is still in custody, and appropriate treatment provided to the individual during that 90-day pre-release period. It also will help the pre-release care manager and the post-release care manager to develop with the member that post-release treatment and discharge plan to make sure that appropriate treatment can continue into the community to continue to improve health outcomes for people leaving incarceration. Of course, also part of this could include medications and administration of those medications that are necessary to treat those various physical health conditions. But for the purposes of today's discussion, we're going to talk and dig a little bit deeper into the clinical consultation services more directly, as well as the laboratory and radiology services. Next. So what is physical health clinical consultation? Though that terminology is terms that we use specifically for this waiver program, and we wanted to make sure that folks are understanding what is included when we talk about physical health clinical consultation. Next slide. So as I mentioned, these are the physical health treatment services that will be provided to individuals in that 90 days prior to release. So it's about making sure that individuals with qualifying health conditions that were able to meet their healthcare needs by diagnosing, treating, and stabilizing those conditions before they are released back into the community. So that might include diagnostic evaluations or outpatient clinical services that treat or stabilize the individual's condition, as well as physician-administered medications or the prescribing of medications to mitigate the impacts of those particular conditions. It also is a way to ensure that we're providing appropriate prescriptions and clinical documentation for all medications and services that will be needed in the immediate post-release period, so that there's a clear treatment plan that follows the individual when they're released from the carceral setting and begin to reintegrate into the community, and that they can be connected not only to their primary care provider to continue treatment, but to specialty care as also may be clinically appropriate for some individuals, depending on the level of acuity or the nature of their condition. So the documentation pieces that go into the reentry planning and the discharge planning are really important to make sure that the individual's physical health treatment services are set up for them as they're leaving the carceral setting and integrating back in with community. It's also a way to make sure that the individuals are aware of the conditions that they may be experiencing or symptoms, and understanding why they're experiencing those symptoms. And it allows for that professional to professional clinical consultation to happen if there is a more complex or chronic healthcare condition that's happening, where maybe there's multiple comorbidities, where you need to really think through the treatment plan and work with another clinician that will be providing treatment in the community setting, or learn from a clinician that was providing treatment prior to the individual's incarceration. Next. So the services include an initial history and physical exam, initial consultation, screening and diagnostic services, which could be done through the laboratory and radiology services, for example, could include immunizations for young people, for youth, or for adults as appropriate, follow-up provider clinical consultation benefits. These services can be provided in the facility through an in-person visit, but could also be delivered via a telehealth consultation with a physician or appropriate clinical practitioner in the community. And the coordination of care conferences are important to help support the reentry coordination and facilitate the linkages to other providers. So the pre-release care manager also has a role to play in making sure that that coordination of care is happening for the individual related to their physical health needs. The services themselves are the evaluation and management codes or visits by a physician or a physical occupational speech therapist, dental professional, or other professionals that are identifying the necessary physical healthcare services and or making recommendations for durable medical equipment. So it's all of those practitioners that are delivering services for physical health conditions and would bill those services as part of the E&M visit. It also does include the screening and diagnostic services for eligible youth as is required under the Consolidated Appropriations Act, as I mentioned earlier in the presentation. Next. So, for example, if you have a patient with hepatitis C, they might have a first visit with a provider. For example, it could be a nurse practitioner in this example, at the correctional facility where the provider performs a history and physical examination. They identify that the patient has heart failure and a need for hepatitis C screening, and they refer the patient to a cardiologist for follow-up care and orders hepatitis C related laboratories. They may have then a follow-up visit by the facility provider to confirm the Hep C status with the patient, and an e-consult request is placed with a cardiologist. Could be a community-based provider that's providing the service via InReach or telehealth services, for example, to discuss the hepatitis C treatment and the impact of the condition on heart failure diagnosis and medications. The e-consult by the cardiologist happens, they make recommendations about hepatitis C treatment options for the patient who has congestive heart failure. And then the follow-up visit by the facility provider happens to discuss treatment options and prescribe the hepatitis C treatment based on the consultation with the cardiologist. Next. The clinical consultation providers could be, as I said, provided either in the facility by embedded facility staff providers or via InReach through community-based physical health providers that are part of the managed care plans network and enrolled as a fee-for-service provider. They can also be provided via telehealth and not face-to-face in the facility. Billing for clinical consultation services are billed using our CHEMIS billing infrastructure, so fee-for-service delivery system, fiscal intermediary. InReach providers will bill for those services under their own NPI number as an enrolled fee-for-service provider, and embedded facility staff providers, those services will be billed under the correctional facilities NPI number as an exempt from licensure clinic. All of the clinical consultation should be billed through the appropriate evaluation and management or E&M codes. And on this page, when you get the deck later today, there's a link to the codes as an example of the types of E&M codes that would be billed for these services. Next. So let's talk a little bit about labs and radiology services. The purpose of labs and radiology services is to help assist in diagnosis and treatment of physical health conditions. So it is the same as it would be in any other healthcare setting. These services can be provided by clinical laboratories, community and county clinics, chronic dialysis clinics, surgical clinics, hospitals, or portable x-ray with x-ray technicians. And hepatitis C antibody testing is an example of the type of services that can be provided through the laboratory and radiology benefit, as well as ultrasound, for example, used to detect liver fibrosis to help guide the hepatitis C treatment, or a urine test to determine if a pregnancy is a factor. So these are all just examples of the ways in which the laboratory and radiology benefit can help assist with the diagnosis of these physical health conditions to help the correctional facility staff or InReach providers to be able to deliver an appropriate treatment plan for the individual during that pre-release period. So we're part of the reason why we're walking through all of this is not to tell you how to provide care. We know that your providers know how to do that, but what we wanted to do today is really walk through and make sure that folks are understanding all of these things that you would do in the normal course of treatment for hepatitis C, for example, are billable service interactions under this program, and not just the care management pieces, but all of the services that support the treatment for physical health conditions that are included as a part of this waiver. Next. So some of the considerations around a short-term stay, in terms of our short-term model, you know, we know that for people who are incarcerated for a very short period of time, that you're not providing a whole host of physical health services to those individuals during the first couple of weeks. But for people who are having a longer term of incarceration, and with, like, for example, within the 21 days of aid code activation, we do expect clinical consultation to begin for those individuals who have a longer period of incarceration. And that services are provided, you know, as clinically appropriate and on an ongoing basis, based on the needs assessment and clinical consultations and the treatment plan that was developed for that individual. Next. All right, so we kind of talked through a little bit of an example for a patient with hepatitis C, but just to kind of illustrate this further, we will walk through an illustrative patient journey. Now, we know that this is just illustrative, it's just an example. There are many different types of patient journeys that will happen in a correctional facility setting, but we have this example to share with you today. So we'll start to walk through that on the next slide. So in this case, the fictitious person that we are examining is Isabel Garcia. Isabel is 2 months pregnant, has known, identified or known medical or behavioral health issues other than pregnancy, which is a qualifying condition. This patient could be in a county jail or in a prison post-trial, for example. The Medi-Cal status is suspended, but still assigned to a managed care plan because Isabel had coverage prior to her incarceration. And the JI aid code is activated 90 days prior to the known release date. The care management model is an embedded model, meaning that the pre-release care management services are provided by the correctional facility staff, who will do a warm hand, or contracted providers who will do a warm handoff to the community-based post-release care manager. Next. So in this example, Isabel is enrolled in Medi-Cal 5 months prior to release, and it's determined that she is 2 months pregnant. So that happens the beginning of the incarceration through their initial health, through the initial screening, and Isabel is already enrolled in Medi-Cal, and it's determined that Isabel is previously enrolled in a particular managed care plan. Isabel received a portion of her pre-release services upon intake. That's how it was determined, the pregnancy status, as well as ruling out some other health conditions. But once Isabel was sentenced to a longer term, the JI aid code was paused until the 90 days prior to her release date. In this case, the correctional facility should continue to provide services as clinically appropriate to Isabel. However, those services are not reimbursable under the Medi-Cal program outside of that 90-day pre-release period. So those initial services that were provided at intake are billable, but then the aid code is paused. Care continues, but those are not reimbursable services until the aid code is reactivated at the 90 days prior to Isabella's release into the community. So then on the next slide, you'll see where that 90-day period hits. The JI aid code is reactivated, and services that Isabel is receiving based on her treatment plan are again reimbursable, and provided throughout the remainder of Isabel's incarceration. Isabel is assigned to an embedded care manager at this point, who leverages Isabel's health history prior to incarceration, medical care that she's received from intake to that point in time, to help inform the health risk assessment and the post-release treatment plan. The embedded care manager and the treating team identify the need to conduct the 20-week ultrasound, as is typical for a pregnant individual, and orders and the physician orders laboratory services during that period as well. And through a meeting with Isabel to complete the health risk assessment, the care manager establishes again that the Isabel doesn't have any additional needs for physical health, behavioral health, SUD, housing, or any other issues. So the health risk assessment is really focused on the needs and goals for pre-release services and post-release care for the completion of Isabel's pregnancy. And you see kind of the key at the bottom shows you where these services are billable to the various systems and using which codes, for example. Next. So Isabel then receives her ultrasound, which is billable through our fee-for-service delivery system, and pregnancy labs related to her pregnancy. She also receives prenatal vitamins, which are billable to Medi-Cal fee-for-service. She has regular monthly visits with her pregnancy provider, who is a nurse midwife, and there's clinical consultation happening. And then the embedded care manager creates a reentry plan, identifying a pregnancy provider close to Isabel's home that is enrolled in the managed care plan network, and the ECM provider will help to schedule those appointments, make sure that the health records are shared with the provider, and make sure that Isabel is connected to post-release care options. Next. 4 weeks prior to release, the correctional facility staff contacts the JI liaison, and Isabel is assigned to the MCP for the post-release ECM assignment. And then that kind of coordination and warm handoff will happen, where both the post-release and pre-release care manager work with Isabel to review the reentry care plan, to do the warm handoff, to make sure that all of the prenatal providers and postnatal providers are identified, including a pediatrician for the child once the baby is born. And then upon release, the embedded care manager then goes over the completed reentry plan with Isabel, and the pre-release care manager sends a copy of that to the ECM provider and the managed care plan for follow-up. Next. Within 1 day of release, the embedded care manager ensures that Isabel receives a full supply of her prenatal vitamins. And then within 1 week of release, Isabel meets with her post-release ECM provider to continue services in the community. All right, so that is our example. I'm sure that you might have questions, but again, these are just examples that are meant to illustrate the different points and service interactions that are billable. And really this discussion today was about kind of making sure that folks are tracking, like I said, that it's more than just the care management services that are billable, but all of the clinical consultation services as well. Next. So just to summarize what this would look like, the care management would be provided by an embedded provider who would do a warm handoff to an inReach provider or a post-release provider, and clinical consultation in this example is provided by the embedded or correctional facility staff or contractors, which include the regular monthly visits with a pregnancy provider, laboratory services, and radiology as well. And those services are billed through the KEMIS fee-for-service delivery system. Next. The medications are billed through Medi-Cal RX, and that includes the prenatal vitamins and the medications upon release as well. So, and I already talked about the ultrasounds and pregnancy lab tests, which would be billed through our Medi-Cal fee-for-service KEMIS delivery system, billing system. Next. All right, with that, I think we're going to take a quick break. I know we just gave everybody a ton of information. We're going to let you digest that, and then we're going to come back and do a live Q&A. In the meantime, we will take a look at the Q&A in the webinar and start to answer those questions as well. But we want to give folks a little bit of time to think about what you just heard, so you can come back and ask questions. I'll also, before we go on break, remind you that we're going to do breakout sessions later in today's session, and we want to have you all be thinking about, what does this mean for you? How would you go about implementing physical health clinical consultation? So as you're taking your break, start to think about, like, how did what you just hear, what questions did it raise for you? What did it make you think about? And how would you go about making sure that folks are getting access to these physical health services as part of the physical health clinical consultation piece? So we'll ask you to share your thoughts in the breakout sessions, and we'll be coming back in about 10 minutes to answer your questions. So we'll come back at 10:54 a.m. and we will resume shortly. Enjoy your break. Thank you. All right, sorry about that, folks. I got a little carried away answering questions and missed the time to come back, but now we're back from the break, so give folks just a moment. But we will go on to our Q&A. So next slide. So we will take questions live for the next 10 minutes. We'll do our best to answer all of your questions. I know that we've been busy answering questions in the chat. A couple of things that I saw from multiple people asking similar questions. First, all of the slides that we have presented from all of these learning sessions will be posted to our DHCS website. We've been having a little bit of trouble with the ADA remediation to get them posted. However, you can make a request to have all of the materials sent to you by emailing our CalAIM Justice Advisory Group at dhcs.ca.gov. We'll put that email address in the chat, and you can make the request for the materials in the chat if you don't have them. And we will get them posted as soon as we can. Get them posted and pass through our EDA remediation process. Another question that we saw multiple times has to do with whether correctional facilities actually have to participate in this program, or if they are able to opt out. And I will say there is not an opt-out option. This is participation by county correctional facilities, including county jails, county youth correctional facilities, and state prisons, is mandated in state law. It was passed as part of the AB 133 legislation, and it is required for all of the county and state facilities to participate in this initiative. But you do have the 2-year ramp up period. So I know we got a couple of questions about that. So I want to make sure folks are tracking. We did kind of go through that in our kickoff session in terms of all of the statutory references and those pieces. But I know folks are now asking, like, do we really have to do this? I will say, I think one of the, as we're going through this particular topic, these services that we're talking about are, already some of the services that correctional facilities are providing. And we want to make sure that in cases where it's clinically appropriate for you to provide services to people to meet their chronic healthcare conditions, including mental illness, substance use disorder, significant clinical conditions, pregnancy or postpartum care, HIV/AIDS, TBI, and for individuals with intellectual and developmental disabilities. We do expect services to be provided to these individuals. At a minimum, the health risk assessment is completed, and identifying their behavioral and physical health needs, doing screening and diagnostic to identify whether these conditions exist. For example, we would expect folks to be screening for hepatitis C, doing laboratories to screen for diabetes, for example, for high blood sugar levels and high A1C levels, we would expect folks to be screening for pregnancy and other physical health conditions that are covered as part of this initiative. So ordering the laboratories tests, ordering radiology services as necessary, and then providing clinical consultation to individuals so that they can start to receive treatment for these conditions that exacerbate health outcomes for individuals as they're leaving incarceration. So these are all required, and it starts with the health risk assessment. That being said, for county jails, we know that that many people or most people that are in the correctional facility setting are not going to be getting a full complement of physical health services to treat the included conditions, because most of the people that are in the county jail system are in a short-term stay model. And so the short-term model that we've talked about in these sessions and have put in our guidance document will really guide kind of what the expectations are for what services are being provided at what point in time of an incarceration for individuals who are incarcerated for shorter periods of time. So we tried to provide some flexibility and some guidance there, but it is required for correctional facilities to participate and to identify these health-related needs for our Medi-Cal members. So with that, those are like some of the big questions that I saw. The other big question that I saw, and then we'll do live Q&A, is around the dental and some confusion around that. So just want to clear that up. Dental is not in scope for the Justice Involved Reentry Initiative. I apologize if that was confusing the way that I laid that out earlier in the conversation. We are looking at whether dental screening needs to be included in order to meet the federal requirements for the Consolidated Appropriations Act, and we'll give additional guidance for that. But it is not included at this point in time for the reentry waiver. So until we provide additional guidance about the Consolidated Appropriations Act for youth correctional facilities only, you should consider dental to be out of scope. And then if we determine that additional screenings need to happen for youth, and then we will provide that guidance so that we can comply with the Consolidated Appropriations Act. Okay. Those were some of the questions that we saw in the chat that I saw multiple times or in the Q&A pop up. But if folks have questions and you'd like to ask them now, we will take your questions. Just go ahead and raise your hand, and we will address your questions live. If I don't see any hands come up, then we will take another couple of questions out of the Q&A and answer those. But I have a hand from Emil Stevens.
Hi, good morning, everybody. I just had a quick question. I know things are just rolling out, but like you said, I know some facilities and service providers are currently participating in just the pre-release, post-release services. My question is, going forward, will there be like a system of enforcement for, like, say, service providers to kind of hold the correctional facilities accountable and just make sure that they're providing those systems? Like, is there, for lack of a better word, a grievance form coming or something where we could say, hey, they're either doing it, or like, hey, they're not doing this and we need this service, just since, if they're listed to provide a certain service, just to make sure that they are providing it?
Yeah, thank you for that question. In the policy and operations guide that's posted on our website, we can put the link to the current version in the chat if we haven't already. There are Medi-Cal members do have rights, and Medi-Cal services are an entitlement, including those services provided through this waiver program. And so it is required for services to be provided to members. And if services are not being timely provided to members, then they do have rights related to state fair hearings, and that's detailed in our policy and operations guide. I will say for correctional facilities, as you all come on board as Medi-Cal providers and enroll as exempt from licensure clinics. That Medi-Cal provider agreement does obligate the correctional facilities to follow Medi-Cal rules and requirements, including enforcement and oversight mechanisms. And as part of the waiver program, we will be rolling out soon, probably in the next, couple of months, as part of these learning series, kind of our plan for conducting monitoring and oversight of the implementation of these waiver of these programs as each county comes on board through the cohort model. So, all right, thank you.
All right, thank you.
Thank you. Eric Gardner.
Hey, I have two questions really. One of them is that when someone is released and they have medical issues and they have medications, are you guys able to send their prescriptions out so they can have their medication when they hit the streets? And the next question.
Oh,
okay,
sorry, go ahead.
And my next question is, as a provider, I'm finding that most of them that are being released don't even know their Medi-Cal number or Medicare number. They don't know their insurance number. And is there a way for them to have that as they get out? So if they do come to another provider, that we are able to help them and not have to search to get that medical number.
Yeah, great. Thank you. The whole purpose of this program is to ensure that that coordinated reentry is happening, that the Medi-Cal members have the information that they need to get services from a known ECM provider in the community. So somebody that they've already met and they know who will be providing service. So that kind of sharing of data and information about the Medi-Cal SIN number and the reentry plan and the treatment plan and all of that should be shared as part of the warm handoff between the pre-release care manager and the post-release care manager. And I understand that that's not what was happening prior to this initiative. That's what we're trying to solve as part of this initiative. And hence all of the various requirements related to the warm handoff, which we will be getting into in more detail in our next learning session, where we're really going to dig in on all of the care management requirements that are part of this waiver program. The other thing I'll emphasize is that this waiver also requires correctional facilities to provide a 30-day supply of medications to the individual in hand upon release. And then the ECM provider would also have information about the prescription, so that if something happens with the prescription, then there's somebody who can help them get what they need from a community pharmacy.
Okay, well, I can tell you that I had someone released and they did not have any medication, and they were told that their prescription was going to be sent somewhere and it wasn't.
Yeah, we only have 3 counties that are live with this initiative right now. It just kicked off like 2 weeks ago. So, right. And so we have until October of 2026 for all of the counties to go live with the initiative. And so we should see some improvements, Eric, hopefully over the course of the next year or two as more and more counties on board.
I'll just add too that there's an element of timing here too. Some folks will go into jails and will not have Medi-Cal when they go into the jail, and they'll be released in a very short time frame. And the program requires the correctional facility to start that application process, but it's possible for certain short-term release folks who aren't on Medi-Cal that they will still get released without a BIC card or a client CIN number. But, for everyone who's in there for a significant period of time, they should have all that taken care of, as Autumn noted.
Good point, Brian. Thank you. That's an important note. All right, thank you. Seth?
Thanks a lot, Autumn. And you answered partially my question in the chat, but I'm still a little bit confused. Let's say we have someone who we've been taking care of under the 90-day pre-release requirements, but they're someone who, let's say, we know they've murdered a few people, and that they still haven't been they've now been adjudicated, and we know they're going to state prison, and that state prison we'll be sending them to state prison 30 days from now. As soon as they're adjudicated and we know that they're going to state prison in 30 days, do we stop the eligibility code, or can we continue to do the care and bill for it during the 30 days between adjudication and when they're going off to prison? Because they're not going to the community, they're going back to a carceral setting for a long time.
Yeah, the intent of the program is to provide services prior to release, as you noted in your question in the chat. I think where we've given some leeway and flexibility in the way that we interpret that is in that pre-adjudication period. If it's not yet known what's going to happen, because they have not yet been adjudicated and or sentenced to a longer term, that it's not only reasonable but appropriate for some services to have begun, but that once kind of that determination is made that the individual is not releasing to the community, will be in fact serving a longer term, then that's when the aid code would be paused. I'll just see if any of my colleagues want to jump in on this, Sarah or others, if you have thoughts about this, please feel free to jump in.
If we do not have Sarah, I believe I have a response that she provided in the chat that I can read.
Great.
Let me pull that up. The response is the Justice Involved Reentry program covers the 90 days prior to a member's release from incarceration. There may be times when a member is transferred between facilities. If the member is transferred between facilities in the same county, that is still considered the same 90 days of pre-release services. If the member is transferred to a facility outside the county or a state prison, that is considered a new episode of incarceration, and the member may qualify for a new set of 90 days of pre-release services.
Yeah, thanks, Brian. That makes some sense. Autumn though really sort of answered more my question, which I'm hearing there's some leeway when you're not sure what's going to happen to the person, but when the person has now been adjudicated and they're going for prison for a long time, the appropriate thing to do is to stop billing for services in your jail. And what you just said also makes sense if we are dealing with, if we don't have necessarily that adjudication, or somebody is still sort of, we don't know what's going to happen to them, then it's legitimate for us to continue what we're doing as long as we're following the pre-release 90-day rules, which you guys both totally made sense. And again, I appreciate these sessions that you do because they help a lot.
Great, thanks, Seth, and thanks for asking that follow-up clarifying question. Stephanie?
Hi, Autumn. This is Stephanie with Yuba County. I was hoping to get clarification or guidance on if an individual is booked into the hospital or provided emergency or urgent care services through the hospital, but they don't meet that 24-hour threshold for MCIP. Can the hospital bill for those services provided off-site, or is that still the responsibility of the county?
Thanks, Stephanie. We know that you guys are waiting for an answer on that. Appreciate you asking it here. I know Santa Clara also asked similar questions about outpatient ED visits. We are still looking at that. We might have some follow-up questions for you all in terms of how you pay for those services today, but I think that we're moving towards a favorable answer, but we need to wrap up a few more things and make sure our legal team agrees with us. We'll take 2 more questions and then we'll need to move on. So Emil, I see your hand is up again. I don't know if it ever went down, but if you have another question, and then we'll go to May, and then we'll move on to the next segment.
Okay. Yeah, this one is pretty quick. I know you mentioned about care planning. I just wanted to know, are medical records from our members' time in jail going to be included in the care planning? And I know sometimes that has to deal with an ROI. So essentially, like, will members be given the option to do that? Just because we're seeing a huge disconnect from the medical records when members are inside, and then the medical records from when they're out, just given the suspension in Medi-Cal. So is there going to kind of be a bridge of that gap when you guys are releasing the care plans?
Yes, there are data sharing requirements, and the pre-release care manager should obtain consent for data sharing to make sure that the post-release ECM provider, as well as any practitioners that'll be providing treatment as appropriate and applicable, and in compliance with HIPAA rules, that the and 42 CFR Part 2, that the appropriate consents are obtained so that data can be shared out. And there's a data sharing reentry toolkit that will come out for folks to comment on shortly. I expect it should be out anytime now, and we'll get some comments on that. So we'll go to May, and then we'll move on to our next segment. I'm sorry, Bruna, but we're going to cut off the live Q&A. You can put your question in the Q&A, and we'll get to it. May? May? Mai? May, are you there?
I
Yeah, can you
think
hear
she was speaking. There she is. Okay.
Can you hear me?
Yes.
Okay, so I put a question in chat and also want to post the questions. Right now, the counties are enrolling the correctional facilities as license exempt under as a provider type in PAVE. So my question is, will there ever be a requirement for these clinics located inside the correctional facilities to meet the licensing requirement under CDPH, which namely is the OSHPAT 3, or you might say HCI 3 licensing standard? Because in order to meet those requirements, the facility will require significant facility upgrade in order to do so. So I just want to post the questions now so that we can alert our county facilities to see if they need to do any renovations and clinic improvements. If they do so, I will have to post that question. Patient care will be impacted.
The exempt from licensure clinic status does not require CDPH to do the licensure approvals, right? So like that's the whole point of using the exempt from licensure clinic status, is that it's not subject to the CDPH licensing and certification requirements. Okay, thank you for your questions. We have more in the chat. We'll continue to answer them and share them out as part of office hours coming up, but next week and the week after. But for today, we're going to move on to our next segment. So if we could advance the slides, that'd be great. So this next segment is going to be focused on our breakout session. So we know that some of you just had questions, but we'd really like for you to get together and really see this as an opportunity for information sharing and brainstorming within your region. So this is an opportunity for you to talk with each other about what you're thinking about physical health services. What are you planning to do? What questions do you still have that, what are best practices that you are thinking about, and share information amongst each other. We will have folks in each room to help facilitate the dialogue, but this is really, these breakout sessions are really an opportunity for regional partners to come together and collaborate and help each other with implementation. So on the next slide, you'll see a little bit more information about that. But let's go to the next slide after that, please. You'll see your breakout rooms. So we're going to ask you to join the room using the, the breakout tab on the webinar. So if you go to more, I think the next page actually tells the instructions. You go to more and join a breakout room, or go to breakout rooms. Click on that and it'll have all of the room options that you can click on and join the room. You see the instructions here. We'll put that back up in a second. Let's go back to the assignments slide. So you see the breakout rooms at the bottom, and we're asking you to go to the room that best fits your county or organization. We have our Northern 1 and Northern 2 regions. We've put folks into these groupings, but it may be that you feel like you fit in a different room better. So please go ahead and go to the room that best fits for you and makes the most sense. And then we'll get into our breakouts and have a few minutes of time together. Let's go down a slide. Sorry, let's go show the instructions again. So click on join breakout room. Go to the room that you're interested in joining, click join, and you'll get over to that room. Let's go to the next slide. Okay, no, sorry, go back up. And maybe show people the rooms again. All right, so we'll see everybody in breakout rooms. There will be somebody here to provide technical assistance in the main room if folks need it. Go ahead and go to your breakout rooms now. A good in your breakout sessions. I know folks are still taking in the information that you heard today and thinking about, how you will implement all of these requirements. So understand if you don't have a lot of questions yet, but as questions occur to you, just remind you that we have office hours next week for county partners, correctional facility partners, and then the week following, we'll have a general office hours session for everybody. Just appreciate your participation and willingness to engage and just for being here today. So thank you. We do have a little bit more to share with you today around care management, and then we'll close out today's session. And then the next long session that we have, the next learning session will be focused specifically on care management. So we will go into a lot more detail in our next learning session, which I think is in 3 weeks. But for today, we will just give a little bit of kind of an overview and intro to the care management pieces as they relate to the physical health clinical consultation services. So we talked about that a little bit throughout the presentation today, but just to flag that that care management is a critical part of this work. So next slide. So the objective of the pre-release care management is to make sure that not only those physical health services are being provided during that pre-release period, but that those services can be coordinated and delivered both in the pre-release and post-release period, that the warm handoff and linkages to services and supports are happening, that the pre and post-release care managers are working together to make sure that appointments are made with community-based providers for the individual upon release, and that they can continue with the treatment plan that's been established while they are still incarcerated. So next. As part of the pre-release care management requirements, we talked a little bit already today about the health risk assessment that needs to be done at the beginning when the aid code is activated. And really the point of this is to help in the in terms of the identification, diagnosis, and assessment of physical mental health and needs, as well as social service needs and health-related social needs, functional needs, and strengths and support resources. So it's really kind of that all-encompassing review to help mitigate risks of that will exacerbate health conditions, and to identify treatment that is necessary for an individual's active chronic or significant clinical condition, including mental illness or SUD. So the part of this is really making sure that that service delivery coordination is happening based on the identified needs, that treatment is happening, that medications are being provided, that DME is being ordered, that data is being exchanged, and consents are obtained in order to share the data, that correctional facilities are obtaining prior authorization or submitting a treatment authorization request for DME as applicable, and that all of that is happening while the individual is still in custody, so that when they get out into the community, there are not barriers to timely access to care and treatment. Next. It's also really important to make sure that all of these care needs for these physical health conditions, as we've been talking about today, are included in the reentry care plan, and that it's identified the care that will be needed for the individual in the community. And so that's part of that whole warm handoff piece to the post-release ECM provider and the managed care plan, so that they can continue to support the individual's whole health needs in the community. So there's really a significant kind of tie-in between the clinical consultation pieces and the care management pieces, because it's really about the care manager identifying the needs and then coordinating both the pre and post-release treatment for any physical health conditions that the individual may have. Next. In the warm handoff session, and we'll go into way more detail about all of this in our next session, and get into a little bit more specifics about the care plan and the handoff meeting and all of that. But these are really important pieces. As you can imagine, you know, you want to make sure that that there's an opportunity for the post-release care manager to be introduced to the individual while they're still in custody, that they're able to start building trust, that they have reviewed the care plan and consents have been obtained for data sharing, that the data have been shared, and that they're actively working to ensure that the individual's needs can be met in the community. So these are really important pieces that thread through all of the services components. Next. And we have the care management bundles, which again, we'll go into in more detail, but all of these care management services that complement the delivery of physical health services are billable activities through each of these bundles. So you can bill bundle 1 for the health risk assessment, bundle 2 for care coordination, bundle 3 for the warm handoff piece, bundle 4 for the reentry care plan, and then bundle 5 for the post-release transition support. And again, we've talked about these before, but we'll go into a lot more detail about each of these in our next session. Next. And here's the rates, and for those bundled codes, there's lots of different activities included in each of these, and you can see the billing frequency that's allowable for each of the bundles. You know, the primary bundles for care coordination and post-release support are bundle 2 and bundle 5. The other bundles we build, you know, one time as those activities are completed for the individual. Next. We previously conducted a training on the 5 care management bundles. That those resources are linked in the slide deck, but again, we'll cover some of this during the next session as well. But I want to make all of these resources available to you as we go through these learning sessions. Next. All right, so that's what we had to share with you today. I know it's a lot of information. There's still a lot of questions. We'll make sure that we compile all of the frequently asked questions as we've done previously, and we will share them in our office hours session next week. And if you go to the next slide, you'll see kind of the timeline for what's coming up. So we have our office hours on the 24th and on the 31st. That one will be very spooky since it's on Halloween. Then we will have our enhanced care management deep dive on the next session on November 14th. There will be one combined office hours on the 21st. Because of the Thanksgiving holiday at the end of November, we won't have time to do the two separate office hour sessions, so there will only be one there. December 5th, we will have a session on pharmacy policy. And then as we look into January, we'll probably take a break after that. And as we get into January, we'll have additional sessions focused on all sorts of different topics, but we'll be seeking your input about which topics you'd like us to focus on for the January sessions, if there's anything that you want us to revisit, or some new topics that we're thinking about as well. So these sessions will continue. Hopefully they're helpful. We'd love to get you more engaged in the dialogue in our breakout sessions, but we are committed to making sure that we continue to have these discussions and dialogue and hear from you all as we go through this process. Next. And this is just a different view of what we just looked at. So you have there at the bottom, though, if you have questions for our office hour session, you can submit them in advance to the Calian Justice Advisory Group at dhcs.ca.gov. And we will make sure that we compile all of your questions, both from today and any questions submitted in advance, to make sure that we can answer those during our sessions that are going to be coming up. Appreciate your time today. I know a lot of you were on this call. Hopefully it was helpful information, and we just appreciate the ability to keep bringing you back every couple of weeks to learn more and deep dive into all of these various topics. So thank you all for being here with us today. We appreciate your time. We appreciate your commitment to this effort. And we look forward to our next session. Thanks, everybody.